So Becky's a senior research officer at Swansea University, specialising in diabetic eye disease, and she's going to do a fabulous webinar for us tonight, telling us all about diabetic eye disease and retinopathy and how it develops, perhaps a little bit about the screening technologies. But I think it's fair to say that she's not going to be talking about the treatment of diabetic eye disease. That's not her area of speciality. So I'll hand it over to you, Becky. By the way, if you've got any questions, drop them in the chat window as we go along so that they don't get forgotten, and then we can come back to you at the end.
Yeah, okay, I'm just going to share my screen, hopefully. Can everyone see that? Yeah.
Yep.
Always a good start. Right. So as Paul said, I'm a senior research officer in Swansea University. So I'm not an ophthalmologist, but my interest in retinopathy began way back in 2003 when I was a retinal grader at the Welsh screening service. So I've got quite a lot of background in grading the images, what those scary letters mean, and how the screening process works, especially in Wales. But I did also work for a time in the Gloucester screening programme under Peter Scanlon. So I do know a bit about how it works in England. It's not that different. And I do know what the setup is in Scotland and Northern Ireland as well. So we're all fairly similar, but as it says, this is all about the eyes. So we'll go from there. So before we start, I thought I'd get you sort of orientated with the retina and what we are actually looking at. So this is a small part of the retina. So the retina goes across the whole of the back of the eye, but this is only a really tiny part that we take the images of. And this is because these are the areas where if anything happens in these areas, then it becomes more immediately sight threatening. And so that's why we particularly focus on these and not the whole of the retina that's there. But basically we have the optic disc here, and this is also known as a blind spot. So this is where all of the nerves, all of the blood vessels come in from the brain into the eye. So there's no vision here as it is, but you know it is an important feature as well. This arrow here is pointing at this darker red area on the retina. So this is what's called the fovea. So this is where you get all of your central vision from, all your reading, all your fine detail, that sort of thing. It all comes from the fovea. So your ability to read is all from this one little spot in the middle. The area around it here, this is called the macular area. So this is basically one disc diameter, so one optic disc diameter all the way around. And this is an important area when we start talking about maculopathy. So that's why I'm pointing that out. And then these are the arcades. You've got your blood vessels, your arteries and your veins. And these are the main arcades then in the eye. But in England and Wales, we take two 45-degree images of the eye. So we take the central, the macular one here that we've just looked at, but then we also make you look at your nose and we take a wider view, the nasal view, which is as it's known. Scotland, they only take the macular centered image. And this is because they believe that any lesions of significance would be picked up from just this one image. But in England and Wales, we'd rather get a wider view if possible. We all love to hate the eye drops, but they are quite important for screening. They allow us to take multiple images of your eyes. So if the eye drops work in that they dilate the pupil, so they make it bigger, allow more light inside it. You get the same effect by sitting in a dark room for 10 to 20 minutes. But that method wouldn't fix the pupil, so it wouldn't stay dilated. So as soon as that really bright flash comes from the camera, the pupils constrict and we can't get a decent second or second image or take the second eye either. Younger people have faster pupil recovery time, so it is possible in somebody maybe under the age of 30 especially those with blue eyes. If you have brown eyes like me, our pupils don't dilate as quickly. They don't react as quickly as blue eyes do. So it could be possible in those younger people, you might get away with not using eye drops. But as we get older, we do really need them to get a decent image. So then we go into background retinopathy. So this is the first level of retinopathy, this first sign of changes that we would see in your eyes. So this is an R1 level. It's a really wide category. So you can have anything from a single microaneurysm, which is a small red blood spot, which is, you can might just, if your eyesight's good enough, see it here where I'm pointing. There's a red, really small red dot. Now these are the really first signs of changes, and if we don't have a good enough photograph, we can easily miss these. So that's why the eye drops are so important. But this category goes from a single microaneurysm all the way up to several hemorrhages, so several large bleeds. So in this image here, we've got 1, 2, 3, 4, 5, 6, 7, 8. You know, we've got more than 8. We've got quite a few hemorrhages going on in this eye. And then in this eye, we've also got some cotton wool spots. So these are white patches, which are ischemic, so they're lacking in oxygen. So because the blood is leaking out instead of being supplied all around the eye nicely, they become oxygen deprived or ischemic. So these white patches. It's also, this eye's also got some exudates, so fatty deposit lipids that are leaking out of the vessels as well, going on. So it's quite a wide category. So when you get a screening letter back that says you've got background retinopathy, you really don't know whether you're down this end or whether you're up at this end, unfortunately. But you know, it is background retinopathy, so it's not sight threatening. We would only rescreen you in 12 months time for this category, but we would recommend really trying to concentrate on looking after your blood glucose levels, your blood pressure and your lipids, and it can really make a difference, big difference in delaying any of this retinopathy from getting any worse. Ooh. Oh, too far. Oh. Right, so then we've got maculopathy. So maculopathy is graded separately from retinopathy. And it can occur at any point with retinopathy. So it can occur when you've just got background retinopathy or when you've got pre-proliferative or proliferative retinopathy, which I'll go on to talk about later on. But maculopathy is lesions that appear within that macular area that I pointed out in the first slide. So that one disc diameter circle around you, any lesions occurring within there would be thought of as maculopathy. So here we've got those exudates again, so the fatty deposits. In background retinopathy, they would be out here, but as soon as they come into that macular area, it is now maculopathy. And we're just really protective in screening over this fovea because we know how important it is, and any issues in this area can be sight threatening. Now, because we are protective over this area, we do over refer maculopathy. So a lot of the times we would refer this eye here on the left, we might refer this into ophthalmology. They'd have one check and they'd come straight back out to us at screening. So being referred for retinopathy doesn't necessarily mean you're going to lose your sight or that you're going to need treatment. It is just for those extra further tests that the ophthalmologist can do that we can't do in screening. Because from this image here, I can't tell. What we want to know is whether there's any fluid leaking within the retina itself, and I can't tell that from a flat 2D image. So in ophthalmology, they would take, they use what's called an OCT camera. So it's optical coherence tomography camera, and that measures the thickness of the retina to see if there's any swelling, any fluid buildup within. So that's what we need. That image is what we need. And that then determines whether or not there's any need for treatment, depending on how thick it is really. But so this first eye here, although it's maculopathy, it is quite early, and they may well just come straight back into screening. These last 3 images here, these are more significant maculopathies. The X states here are forming a circle. So this is a cercinet. And in the center of this, we could suspect that there would be some fluid buildup, some swelling, some edema forming. And certainly then in these 2 images out here, and definitely this one, I would suspect that there would be some fluid buildup underneath this. So this is all maculopathy. The treatment for this is now anti-VEGF injections. So VEGF stands for, oh God, I can't remember now, but anti-VEGF injections. They would inject things into the eye that inhibits the VEGF production, and hopefully stops this developing and getting any worse. If you do, there are some services in England, I believe, that have the OCT cameras as part of screening, and they would then have screening surveillance clinics at 3 to 6 month recalls. So you could go into one of those, but in Wales we don't have those as yet. Maybe something for the future, but yeah, we haven't got the OCT cameras, so we would refer you in to ophthalmology just to have that extra image taken. At this point, it would be still really important to optimize that blood glucose management, blood pressure and lipids. It really can make a difference in helping to limit the amount of treatment that you might need. Going back to retinopathy, we've got this pre-proliferative level. So this is now, we're into the R2 stage. So we've gone from those multiple hemorrhages and microaneurysms. There's a lot more hemorrhaging and cotton wool spots going on in this stage of retinopathy. So we've got quite a few hemorrhages here in this eye. This eye has an awful lot of cotton wool spots. So if you remember, these are the ischemic patches, so they're not being supplied with oxygen. And then in this eye, we have all of it going on, as well as some exudates. And then this final eye, we've got some changes going on in this vein. I don't know if you can see them. It's especially down here. But what we like to think about when we're looking at this is called venous beading. So it's changes in the shapes of the veins. But if you think of a string of sausages where all the meat is, they're fat, and then where you twisted all the skin together, it becomes thin, and then it gets fat again. That is what is basically happening in this eye. This is what it looks like in this vein. It's thick and then thin and then thick and then thin all the way along it. So you've got some changes going on there. Again, in Wales, we would probably refer you into ophthalmology at this stage, but in England, you do have some areas that would have surveillance clinics. So you'd be on 3 to 6 months recalls. This stage doesn't yet require treatment, but we really would be monitoring this because this would be at risk of developing further now into the proliferative category. And we'd want to pick that up as soon as possible. So when we go into the proliferative retinopathy, so this is the R3 stage, you're looking at new vessels forming. So this is where those ischemic patches, those areas that the eye isn't getting any oxygen, the eye is trying to resupply those areas with oxygen. So it's growing its own vessels. So in this image here, we've got some here on the arcade forming. We've also got some on the optic disc here, all these squiggly messiness on the optic disc. Second image now, we've got them here. And then the problem with these new vessels is that they are really weak and fragile, and they'll quite easily break and then start bleeding. So then we get these pre-retinal hemorrhages. These are these boat-shaped hemorrhages on the eye. So it's a straight line at the top, and then it dips down into like a boat shape. So these are pre-retinal hemorrhages, and then if they continue on from this stage, they develop into a vitreous hemorrhage. So this is the new vessels are growing out off the retina into the jelly-like vitreous substance that's in everybody's eyes, and they break and they bleed, and they will fill the whole eye with blood. If you do get a vitreous hemorrhage, the ophthalmologist can't treat it at that stage. They have to wait for the blood to be reabsorbed by the eye so that they can see actually the area that they need to laser. So there would be a delay in treatment until this sort of resolved at this point. Ideally, what we want to be doing is using laser in this sort of stage when we've got the new vessels just starting to grow, because then we would need less laser therapy, and it would be treated a lot quicker. And at this stage, we'd need quite a lot of laser to treat some of these images. And laser itself is a destructive process. It's actually killing the retina that it touches. And that's to stop the eye then thinking that it needs to keep resupplying that area and keep growing in these new vessels. So we don't want to use too much laser, so we maintain as much vision as possible, but we need to use enough laser so that we don't get any more growth of new blood vessels. You can use anti-VEGF therapy in this state as well as the maculopathy, and they've had great success, and it actually helps to regress the new vessels as well, so that again you need less laser therapy. So why do we screen? It's because retinopathy, you wouldn't notice any changes to your vision until quite a late stage. So it's probably when these bleeds start happening, or when the fluid is already leaked in maculopathy, that you would actually notice any change to your eyesight. And treatment works better if it's done earlier than that. So we get a better visual outcome from the treatment. So we screen so that we can detect it at the earliest stage when the treatment is most effective. So that is all about retinopathy and what those scary letters mean that you get from screening all the time. But basically the main message is, if you are referred from screening into ophthalmology, it's more to get extra tests rather than you need treatment and there's something wrong. We're just being, extra cautious because there's only so much we can see and do in screening. So when we go on now to look at the risk of progression, so if you've got no retinopathy in your eye, your chances of developing referable eye disease within the next 3 years is sort of 1 in 50. So it's quite a low risk within the next 3 years that you're going to develop a serious problem. If you've got background retinopathy in one eye, this risk reduces to a 1 in 50 chance within the next 3 years. If you've got background retinopathy in both eyes, then this chance really does reduce to 1 in 4 within the next 3 years that you might develop a referable level of retinopathy. So once you've got background retinopathy, your risk of progression is that much more. So what we want to do is try and delay it developing for as long as possible, really. So what are the risk factors for retinopathy? So there are a lot of risk factors, but there are things that you can change, things you can do something about, and there's things that you can't. So your if you've got high blood glucose, if you've got high blood pressure or high cholesterol, if you can lower these, then you do reduce your risk of developing retinopathy. It doesn't reduce to 0. There's still a chance that you could develop it, but it does reduce. The things you can't change, you can't do anything about how long you've had your diabetes for, unfortunately. Ethnicity, so if you're South Asian, if you're African American, you are at higher risk of developing retinopathy. When you become pregnant, unfortunately, there is a higher risk of retinopathy developing. It could be from the pregnancy hormones, and it could be from reducing glucose levels. Puberty, there is some evidence, although it's a bit shaky as to which way it goes, that puberty plays a part, and I think it's probably something to do with the hormones. around at that time. And your genes, your genes do play a big part, because even if you have been, managing your blood glucose forever and it's always been really good, you've never had a high HbA1c result, you could still develop retinopathy. And we've seen it in some who've had really high HbA1cs all the way through having diabetes, and they never get diabetic retinopathy. So it really is something going on in the genes that we really don't know about, and there needs to be more research into that. So this slide tends to get a bit scary, I think, but it's basically saying that after 20 to 25 years of having type 1 diabetes, 80 to 90% would develop some form of retinopathy. Now, most of that is going to be the background level. And you can see here, I've segmented off the referable retinopathy. So that's the dotted line. So that is about 20 to 30% would develop referable retinopathy after 20 to 25 years. So it's a lot less than the any retinopathy line of 80%, because obviously that kind of seems like it's going to be inevitable that everybody will develop retinopathy, but it is the background level that we're looking at mainly in this line here. And this study, this was a systematic review of, I can't remember, about 32 different studies looking at progression of retinopathy. And these HbA1c results here, these are in old money, they're in percentages. So if you have an HbA1c of 7% or less, then around about 18% will have some form of retinopathy. And 5.4 of that would be of a vision-threatening retinopathy level. So that is your proliferative and your macular edema levels, your maculopathies. So even at low HbA1c results, we still find some people getting diabetic retinopathy, unfortunately. But as the HbA1c increases, so once you get above 9%, 51% would have some form of retinopathy, and 18% of that would be the vision-threatening level. So it is quite a big jump between those HbA1c levels. Blood pressure hasn't got as much of a jump, but it still does makes a big difference in these sight-threatening categories. So if you have a blood pressure of 140/90 or less, then 31% would have some form of retinopathy. Once it's above that, it's almost 40%. And the vision-threatening forms go from 7.6% up to 18%. Again, total cholesterol levels, they don't play a huge part in the retinopathy levels. It's more the maculopathy side of things that they seem to have a difference. So if your total cholesterol is below 4, then 4.6% would have a diabetic macular edema, this refers to. Once it's above 4, it increases to 6.8%. I don't know how many of you are aware or know of the early worsening of retinopathy phenomenon, but it has been shown in several studies. So if you have retinopathy present, then a large and rapid reduction in HbA1c has been shown to worsen the diabetic retinopathy and make it progress quicker than it normally would. So it's been shown in studies of initiation of insulin therapy in type 2 diabetes. It's also been shown in intensification studies. So that big DCCT trial actually showed it as well. We've seen it in pregnancy and also following bariatric surgery. And the latest one was in the initiation of GLP-1 therapies, the semaglutide. So that was the SUSTAIN-6 trial. But what do I mean by large and rapid? So in SUSTAIN-6, it was a 2% reduction was seen in the first 16 weeks of the study. So what we say is 2% reduction in a 2 to 3 month period would be at risk if the retinopathy was already present. If there isn't any retinopathy, then there is no risk of it actually developing. And this is mainly seen in those who already have a HbA1c of over 10%. So if you have a HbA1c of 8% and you're going to reduce it down to 6%, it's probably not going to have an issue. But at the higher HbA1c levels, if you do have this rapid reduction, then it could be a problem. It's something that you should be aware of and to look out for. It's not always something you can control. So if you start a new technology, if you start GLP-1, a new therapy, then you need to be aware that this is a risk so that you attend your screening. And if you are under an ophthalmologist, then they should be aware that there's a potential that this could happen so that they can monitor you more frequently, basically. Because obviously, as we know, a lower blood glucose levels, a lower HbA1c, it has far-reaching consequences. So it goes way beyond the eye and has, benefits for all the other organs in your body. So we can't be saying to people, don't do it. But if you can do it slowly and gradually, so, maybe 1% over 6 months, it would be better than trying to do it all in that really initial period. There is another treatment for retinopathy, and this is a statin. It's called fenofibrate. It's been shown in 2 studies. This field study, which took place in Australia, and then the Accord Eye study, which was a European trial. They used fenofibrate. It worked on the retinopathy even when it didn't lower cholesterol levels. So they're not really sure what the mechanism of action is for fenofibrate. But it has been shown to reduce the progression of retinopathy, and it mainly works in the maculopathy states, and ophthalmologists do quite like it. But it's only had its license changed in Australia. So fenofibrate in Australia is licensed for use in diabetic retinopathy, but it's not in the UK or any other country as far as I'm aware. So it would, if fenofibrate is mentioned by an ophthalmologist to be used, it would need to be a discussion between primary care and secondary care to try and see whether or not it would have any benefits, and what the consequences, side effects and things that they would need to think about. As I've mentioned, as we've gone through, there is treatment available for retinopathy. So if you do develop sight-threatening retinopathy, there is treatment. It doesn't automatically mean that you're going to lose your sight. We've got laser that's been around since the 50s, I think it is. This will seal the leaking vessels. It reduces the regrowth of new vessels, and regresses them as well. The newest therapy we've had developed is the anti-VEGF, vascular endothelial growth factor. That's what it stands for. It blocks that and reduces it. So that then slows vessel leakage and slows the growth of new vessels as well. There's intravitreal steroid injections. These reduce the exudates and the inflammation in the eye. And then eventually there is vitrectomy. And this is removal of that vitreous gel in the eye, and that will then remove the new vessels and can remove any scar tissue as well that can affect eyesight. Because you have diabetes, unfortunately, you are at higher risk of other eye conditions. So you're more likely to have a refractive error. So you're more likely to need glasses. It can cause diplopia, which is double vision. And then you are also at higher risk of developing cataracts, and those cataracts come in earlier in life than people without diabetes. And you're also at risk of developing glaucoma. So as well as attending screening, you should really attend optometry, your opticians as well, because they're the ones who check for these things. Screening don't. And this is my last slide. So my take-home messages: sight loss and blindness due to diabetes is not inevitable. Just because you have diabetes doesn't mean that you will go blind or you will develop a sight-threatening form of retinopathy. I think that's the biggest take-home message. If retinopathy does develop, progression can be slowed or delayed, especially if you make changes to your blood glucose and blood pressure. It really does make a huge difference in delaying the progression from happening. But if retinopathy does progress and you do develop sight-threatening retinopathy, there is treatment available. And the earlier the treatment is used, the better your visual outcome will be at the end. Genetics plays a role. There are studies that have shown, you can have really low HbA1c levels all of your life and still develop diabetic retinopathy. It's not a given that lower blood glucose levels is going to, take your risk of developing this to zero. It's not. But it ain't your fault. You're trying your best to manage a 24/7 condition. And it's not easy. It's definitely not easy. So please attend screening and please talk to your diabetes teams for any advice that you might need. And I think that is it from me, yes. So I will now stop screen sharing, I think. Here we go.
Thanks, Becky. That was absolutely incredible and very, very informative. I've had a few questions come in as you were talking. So the first one I've got is from Louise. So Louise, do you actually want to ask, or do you want me to ask on your behalf?
Yeah, I don't mind. Hi, Becky. Thank you for your time, first of all, and Paul as well. So I've had type 1 for 22 years, and over the years, well, the first few years fine, but then over the years I had a few bleeds, and the next time they would have gone, or there might be another one in a different place. But earlier in the year, this year, April, I had my screening, and all of a sudden I needed urgent laser treatment. And as far as I understand it, the laser treatment is they just crack on and do it within 2 weeks anyway, certainly in my area, which was brilliant. I don't understand how that happened in a short period of time. It was shocking. But I did have COVID over Christmas, and I wondered if you know, or if there's proven to be any link that it might accelerate it or affect it in any way.
That isn't known. It's going to be part of a future study that we're going to be looking at, and I think there's probably other studies ongoing looking at it. It's possible that that it could have an effect, but we're really not sure at the minute.
Yeah, I thought that probably would be the answer. I mean, I've got other symptom, COVID type things. I wonder if I might have long COVID, because I know everybody is, but I'm still just absolutely exhausted all of the time, and out of breath running up the stairs and so on. So I wondered if having that, even if it is, I don't know if it is long COVID, I've not been to the doctor, but I thought perhaps it did have an effect. I don't know, but it's kind of just it's shocking, really. Not, it's horrible.
It's not nice at all.
Thanks, Louise. I've got it's not really a question as such, but Paul Pritchard has made a point here in terms of reading about people with type 1 diabetes getting diagnosed, and then they go on to reduce their A1C rapidly. And he's saying that there doesn't seem to be a connect between healthcare professionals discussing this with them and suggesting a slower reduction. I tend to agree from my own personal experience. I'm only talking from an N=1 point of view, but I don't know, is there any evidence that that is happening, Becky, that those conversations are happening?
I don't know. I don't work in a diabetes clinic as such.
I didn't know whether maybe you'd seen it in the epidemiology data.
No. I think it's a subject that people forget about. But when you're newly diagnosed with type 1, it's not really that much of a risk because you don't have the retinopathy already there. But certainly in type 2, it could be. because the retinopathy can develop before you're actually diagnosed in type 2. But yeah, I think it's a topic that tends to get forgotten about by a lot of people. So I do like to try and raise awareness of it whenever I can, whenever I do a speaking session, just to remind people that it is something to bear in mind, and you should be having these conversations with your patients so that they are aware of the risks that they are taking as well.
And next question I have is from Mo. Mo, are you happy to ask a question?
Yes, happy to give it a go. Let me know if my internet connection is dreadful. So it's a pair of questions, the second one of which might not be entirely in your wheelhouse. But the first one, I've heard that some high intensity sport or kind of really exerting activities can worsen your existing retinopathy if it's already at a certain point. The example I heard was, you know, if you were kind of a competitive weightlifter with kind of R2 pre-proliferative level retinopathy. That's not my exact circumstances, but is there any truth to that?
I wouldn't have thought so for the pre-proliferative level, but certainly if you've got proliferative, if you've got new vessels developing, they would tell you you really should be looking at not doing high intensity exercise until it's fully treated, because it could make the blood vessels burst earlier, and so you could have the bleeding coming out. But in pre-proliferative, it wouldn't really push you into the proliferative level because you need those blood vessels to grow. So, but yeah, certainly in the proliferative level, you don't want to be doing any serious weightlifting or anything like that.
Cool, but that's the sort of thing where if my retinopathy progressed to that stage, I would expect to be told, like, throttle it back.
Yeah, yeah, your ophthalmologist should have those conversations, or you should bring it up with your ophthalmologist then, at least, you know, what sort of exercise am I okay to do? And, you know, things like swimming and, you know, all those sorts of things are fine. But yeah, the higher intensity would be a problem.
Cool, thank you. Paul, can I ask my second question?
Yes, go for it, Mo.
Brill. So thanks, Becky, again. This might not be quite your wheelhouse, like I said, but I can't really find the answer to this easily anywhere else without it becoming too vague or too terrifying. What would be the signs of kind of a sudden bleed in the retina or in the eye, or kind of what sort of changes in my sight should I watch out for? And more importantly then, who would I contact if I think it's happened?
So to contact, your best bet is either to go to hospital eye casualty or your optician, because your optician could check it for you in a quick way. And you're really looking for signs, flashes of light, or I'm trying to think of the words now. Yeah, it's sort of flashes of light. Or Paul, you've experienced it, haven't you? So what was your experience?
Actually, I've not had a bleed.
Oh.
So my experience has only been from maculopathy and having some extensive laser treatment on that. So I can't actually speak from personal experience. I can relay what I've heard other people tell me with having cloudy vision or loss of vision or getting a red tint to their vision.
Yeah.
But whether there are other symptoms, I honestly don't know. I've not looked. Probably out of fear, for being honest. So Yvonne has made a point on here about this is all well and good, providing we can get screening, which kind of lines me up to asking a question. There's some work going on about moving screening to instead of annual screening. Is that a good or a bad thing? You know, I know here in Wales we've been struggling to get annual screening because of lack of capacity, but could moving to 2-year screening actually be a benefit beyond just getting an appointment?
There's quite a bit of evidence behind 2-year screening. And basically it's that risk, if you go back to that slide that I showed you, of if you have no diabetic retinopathy, your risk of developing a sight-threatening version of it in the next 3 years is really, really low. So screening has reached capacity. We can't screen everybody annually. We just can't keep up. So the only answer would be give screening more money, but then obviously there's only so much money to go around. So they could employ more graders and more photographers, or move to 2-year screening for those who are really likely to be low risk. And I think the theory is that if we move those who are that low risk out to 2-year screening, it would then free up capacity for us to make sure everybody with background retinopathy has annual screening. And then those with pre-proliferative retinopathy or maybe even maculopathy could be seen in 3 to 6 months, every 3 to 6 months. And also pregnant women. Pregnant women need more frequent screening, so they need to be seen every 3 to 6 months anyway. So, you know, it really would free up some capacity in the system to allow us to make more changes and to see people more often who need to be seen. So it does have quite a few benefits to
I think that there's been a pilot project on this running in Liverpool that showed some really promising results.
Yeah, the Liverpool study, they've done the largest ophthalmology study actually on 2-year screening intervals. And yes, they take more than just what your level of retinopathy is. So they would also look at your HbA1c level, and I can't remember what other, blood pressure would be another factor, but they had a lot more data than what screening can do. So they can really sort of risk stratify, you know, and make sure it is safe for you to go out to 2 years. I think they've had a lot of feedback in that if there are changes, so if all of a sudden your HbA1c level goes up, or, you know, you're worried there might be something going on, they have had feedback in that you could be seen more quickly if you went out to 2 years. You know, there would be a mechanism to come back into the system a bit earlier if something did go wrong. So that is still ongoing in Liverpool, and we're testing that system now in Wales as well, down in Swansea with the Sale Data Bank. So just making sure it is 100% safe.
There's been a couple of comments coming in here, one from Jackie saying that when she had a bleed, she had wriggly worms in her eye, and one from Wendy saying she had a cobweb in front of her eye.
Yeah.
So, and somebody else saying floaters when you have a bleed as well. A question from Jackie. Jackie, are you there? Do you want to actually ask this in person?
Yeah, I'm here. I think I struggle really when I go to ophthalmology. I go every 6 months. I'm very short-sighted and have been since I was very young, as well as having the start of cataract, the start of molecular degeneration and retinopathy. But I struggle to get information when I go to the ophthalmology department. It's I don't know if it's done the same everywhere. You're on a bit of a system and everyone's going in and out and, you know, getting the drops in and various things. But I don't actually get any feedback of what's wrong, how it's progressing, is it getting worse, or even have the chance to, you know, talk about my worries with it, and especially wanting to work for another 15 years potentially. And I don't know if I should expect more or whether I need to write to find out more. I don't know.
I think, I mean, ophthalmology clinics, my experience of them is that they are very rushed, and there is a lot of people trying to be seen and not enough ophthalmologists and not enough time. So I think it's probably a time constraint, because I think if you sit there and you talk to them and ask them questions, if you explain your worries and your fears, I would hope that they would engage in that conversation with you and go into more detail. But I think it's the time pressures on ophthalmology, and there's so many people waiting to be seen, that is the main issue there.
Yeah, because I think it is very hard to get advice as to whether you can be doing anything yourself to keep things on track, and yeah.
I think they're also aware as well that they can't really give you the diabetes advice, because they're not that side of it. So I think there may be some fear in getting involved in those types of discussions. So they should be referring you back to your diabetes team.
Okay.
Help you with that sort of side of things. But yeah, I just think it's a time pressure problem.
Okay. All right. Thank you.
So Becky, another question I have is on emerging technology. You mentioned at the beginning of your presentation about how we all hate the eye drops. So what's the future of screening? Are we still going to carry on with eye drops? Is it going to be something else?
The foreseeable future, we are stuck with eye drops, I am afraid, because screening has, well, in Wales, we've got 24 cameras. So to replace those, change them all, is going to cost a lot of money. Unfortunately, there are newer technologies coming. I mean, I know in ophthalmology, they've got wide field cameras called Optos, and I don't believe you need eye drops with that, but it's a very large piece of equipment and it costs an awful lot of money. So I don't think it's going to be practical for screening. There are some OCT cameras that opticians have that you don't need drops to use. But again, they're expensive bits of kit, and whether or not they've been tested from the retinal photography side of things, I don't know, but yeah, I mean, it would be really nice if we could move away from eye drops. But I think even if we could move to a staged approach, so in Scotland, because they only take the one image, they actually will try everybody without drops in the first instance, and then if that fails, they will then use eye drops. If we could do that in England and Wales, I think that might be one approach, but it would mean longer screening appointments. So instead of you sit in a waiting room for 20 minutes and then get your photographs taken, you'd have to have your photographs, and then if it failed, you would then have to go back to see the healthcare assistant to get your eye drops put in, and then go and wait for 20 minutes. So it would make the whole process longer, but I think it is something that is going to be looked at in the future, because I mean, I don't know if you all saw, but I ran a poll on Twitter this last week, and it seems to be, everybody seems to think that it's the pain of the eye drops that is the biggest issue. But what it came out in the poll was that wasn't, that's fleeting for most people if there is any pain, but it actually causes migraines or makes people so tired that it wipes out the rest of their day. So it's the inconvenience that they cause with the blurred vision, migraines, headaches, etc. That's the bigger issue, and I don't think screening is necessarily aware or taking those into consideration at the moment. So we do need to raise awareness of that.
I think that's quite an important point, because you mentioned about a kind of a double stage appointment and the appointment taking longer. But if you've got the drops, the rest of the day is pretty much wasted anyway. So from one point of view, it's kind of irrelevant. And if we could actually condense get more people through that initial screening phase, and then get fewer people through the more intense screening phase, as in those that actually need it, it might actually be a good thing.
Yeah, I think certainly in England they are looking at it. Wales will usually follow what England do, so eventually. So yeah, I think it's one for the future that they may go to stage screening. It'll certainly be easier and more cost effective than trying to get new cameras in.
Okay, I got another question here. On one of your slides, you said about HbA1c reduction of 2%, which is great, but I think that's just 2% in old money. It's not a 2% reduction in modern millimoles per mole. Just wanted to clarify that.
No. Yeah, sorry, I'm research, and so I'm still old school, old money in my HbA1c reading. So every time I get a millimole per mole reading, I have to convert it back to percentages.
I still have to as well, Becky. So in terms of relating that back to millimoles per mole, is that like 10% or something? 10% reduction? Would that be a reasonable start point?
Yeah, I think it's for 1% is roughly about 10 millimoles per mole, isn't it? So that's the equivalent. So
yeah,
you wouldn't want to be doing 20 millimoles per mole, you know, in that short period of time.
And actually, I think that with more of us getting access to things like Libra, and we're looking at estimated A1C, I think that we're actually in a better place where we can actually manage this. Whereas in the past, it's just been, forgive the pun, but blind.
Yeah. And actually, it's been really interesting to see Fraser Gibb has published some of the Libra studies looking at retinopathy, and there hasn't been any early worsening as far as they've picked up so far, which is quite good news.
There's another question on here from P's iPad. I'm not sure whose P's iPad is. It says, I had 3 laser treatments, then had a massive bleed and have had emergency eye op. I might need laser treatment on my other eye, but can the laser treatment cause another bleed? 32 years of type 1, HbA1c 6.9. Please ask for me.
Laser wouldn't actually cause a bleed. It's just the progression of your retinopathy. So the laser isn't the cause, it's just the timing of it. You know, it's coincidental.
Okay, so I think that we are pretty much out of questions. I'm not seeing any others coming in. Have I missed anything? If I've missed your question, please put it into the chat window now or raise your hand. Okay, in that case, I'm going to wrap up there. Thank you very much, Becky. That's really fascinating presentation. And I think that most of us have found this incredibly useful. I think it's taken some of the myths away around retinopathy and hopefully some of the fears away when we get that dreaded letter dropped through the letterbox from the screening service. So that is absolutely wonderful. And I know that Becky's already done a lot of work on the Diabetes 101 account on Twitter, and she's got some tutorials on this subject. But this is also going to become a podcast, and it's been recorded, so this will also be available from the Transform Your Diabetes website later. Probably take me a couple of days to get the video live, if I'm honest. But thank you very much for your presentation, and thank you for attending. And perhaps I'll see you next time.
Yeah, brilliant. Thank you, guys. That was really good.
Right.
Thanks.
Thank you. Great.
Thank you. Bye.
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 Bye-bye.
Jan.
Hi, Bex.